This is an AI-generated podcast based on a chapter in the book Gastroenterology Clinical Focus by Dr. Emad Qayed. We hope this podcast helps you strengthen your understanding of gastroenterology. Please like, subscribe, and share this channel with colleagues and students who might find it useful.
Welcome to the Deep Dive. Today, we are strapping in for what is, arguably one of the most complex yet rapidly evolving fields in medicine. Inflammatory bowel disease. We're talking about Crohn's disease and ulcerative colitis.
The literature stack here, it covers everything from new biologics, surgical management, pregnancy planning. It's vast.
And what we're seeing, it feels revolutionary. This isn't just small steps, right?
No, absolutely not. We've got new treatment classes, refined therapeutic drug monitoring strategies, major shifts in post-op care, and a completely different way of thinking about surveillance.
So if you need to be current on IBD, this deep dive should hopefully give you that necessary edge.
Exactly. And just to ground us in the scope of this challenge, IBD is common and it's impactful.
How common?
Well, in the U.S., the prevalence is significant. For ulcerative colitis, we see an incidence of maybe 2 to 14 cases per 100,000 person years.
Okay.
And an overall prevalence around 238 per 100,000.
And Crohn's?
Crohn's disease, CD, has a slightly higher incidence, maybe 3 to 20 cases, but a pretty comparable prevalence, around 201 per 100,000.
These are lifelong diseases.
They are. They require continuous, often expensive, and very specialized care.
And while both are about chronic inflammation, the clinical signs are distinct, often pointing us toward the diagnosis initially.
Yeah, that's true. With UC, you're looking at continuous inflammation, often presenting with hematochezia, that's blood in the stool, urgency, tenesmus.
That feeling of incomplete evacuation.
Right. But with Crohn's, the symptoms are much more varied, often related to the small bowel,
Like
deep abdominal pain, unexplained weight loss, and those really specific presentations that scream fistulizing disease like pneumaturia.
gas pass during urination.
Yeah, or even stool in the vagina, very specific signs.
Those initial signs are crucial, but they lead us straight into what you called the biggest shift.
Exactly. The philosophical shift in IBD management, moving from just treating symptoms to treating based on objective data.
And that shift saves colons.
It absolutely does. #TagI. Objective assessment and diagnostics.
Okay, let's unpack that core idea. Symptoms often lie. Or, well, at least they don't correlate perfectly with the actual disease activity inside.
That's the crucial clinical tension, precisely. I might have urgency because of IBS, or it could be my whole colon is inflamed.
So you can't rely just on what the patient reports if you're thinking about changing therapy.
No, you really can't. Not for escalation or de-escalation. You need objective confirmation of inflammation. Almost always that means endoscopy or some kind of advanced imaging.
Even if the patient feels better.
Especially then sometimes. If they feel better, but the objective markers like inflammation on scope or high calprotectin are still there, we're obligated to intensify therapy.
Because we're not just treating symptoms anymore.
We're treating to mucosal healing. That's the goal.
Okay. So beyond the standard labs, the CBC where we look for, say, leukocytosis.
Right. Could be infection, could be steroids.
Or to leukopenia.
Which might point to thiopurines causing bone marrow suppression.
And the chemistry panel's checking electrolytes.
We lean heavily on specific inflammatory biomarkers.
And the undisputed superstar there is.
Fecal calprotectin, no question.
What is it exactly?
It's a neutrophilic cytosolic protein. Basically, when neutrophils, those key inflammatory cells, are active in the gut, they release this protein into the stool.
So stool levels reflect gut inflammation.
Exactly. It's an excellent non-invasive barometer for intestinal inflammation.
And its main clinical use right now.
Well, first, it helps us differentiate. Is this inflammatory diarrhea needing IBD treatment or something non-inflammatory like IBS?
What's the cutoff?
Usually, a cutoff greater than 50 to 100 micrograms per gram strongly suggests active inflammatory disease.
Okay. And second use?
Guiding therapy. This is huge. The landmark CALM trial in Crohn's disease really showed the power of this treat-to-target strategy using FCP and CRP.
How did that work?
By escalating therapy based on these objective markers, rather than just waiting for symptoms to flare up, they achieved much better rates of mucosal healing and long-term remission.
Makes sense. Now, we also have those IBD serum markers, ASEA, OMPC, CBI-AB for Crohn's, PANCA for UC.
Right, the IBD panels.
But the sources seem pretty clear. Routine use isn't really recommended in clinical practice.
Exactly. They're interesting for research, sure, but their sensitivity and specificity often aren't high enough to reliably guide therapy decisions on their own.
You mentioned one specific one.
Yes, anti-CBR1. It's worth flagging because it's specifically associated with the more aggressive, problematic forms of Crohn's, the fibrostenotic scarring type, and the fistulizing type.
So it can inform prognosis, perhaps.
It might help you anticipate a tougher disease course, yeah.
Okay, moving to actually looking inside. Endoscopy reveals those classic differences.
It does. UC typically presents as continuous inflammation, always starting down low in the rectum and moving up. The mucosa looks granular, friable, like a sunburn inside.
If we score that.
Yeah, with the endoscopic Mayo score 0 to 3.
Versus Crohn's.
Very different picture. Crohn's gives us segmental colitis with skip areas, patches of disease separated by normal-looking mucosa.
And the look of the disease itself.
You see a whole spectrum, from mild aphthous ulcers like little canker sores up to deep linear ulcerations and that famous cobblestoning appearance.
Where the mucosa looks like bumpy cobblestones.
Exactly, because the inflamed, swollen mucosa is separated by deep fissures.
Now, this brings us to technology that's changing the game. Intestinal ultrasound, or IUS.
Yeah, IUS is really gaining traction, especially over in Europe. It's inexpensive, non-invasive, and you can repeat it easily in the office.
So good for monitoring between scopes or MRIs.
Perfect for that. Assessing activity, checking treatment effectiveness without a full prep and scope. The key thing we measure is bowel wall thickness.
What's considered abnormal?
Generally greater than 4 millimeters in the sigmoid colon or greater than 3 millimeters in the descending colon.
And that measurement means something clinically.
It does. What's powerful is that this thickness correlates remarkably well with the endoscopic Mayo score. So it gives us a non-endoscopic objective measure of how the mucosa looks.
Very useful. For the small bowel, though, we often hear about capsule endoscopy in Crohn's.
Yes, it's highly sensitive, especially for catching early small bowel CD if an ileoscopy was negative. But and this is a major clinical caveat.
Risk of retention.
Exactly. It's real and potentially dangerous. The capsule can get stuck. The retention rate is maybe 4% in suspected CD, but jumps to 8% in known Crohn's.
And retention can mean obstruction, surgery.
Correct. So you absolutely must rule out small bowel strictures first, usually with the patency capsule, a test capsule that dissolves, or other imaging like MRE or CTE before you do the video capsule.
So not just routinely after a negative MRE.
No, the added yield probably doesn't justify the risk in that scenario.
Got it. And finally, histology. Biopsies confirm things. We see general findings like cryptitis, abscesses.
Architectural distortion, yeah.
Yeah.
But the really characteristic finding for CD on pathology.
Granulomas.
Non-caseating granulomas. They're considered the hallmark, but here's the interesting bit. They're actually only present in less than 30% of cases.
So not finding them doesn't rule out Crohn's.
Not at all.
Okay, before we dive into treatment, we have to pause for the health maintenance checklist. This feels really central to good IBD care.
It's absolutely critical. Preventative medicine at its best. Vaccinations are number one, especially with so many patients going on immunosuppression.
Which ones are key?
We focus on the non-live vaccines. Annual flu shot, definitely. Pneumococcal vaccination, PCV20 or PCV21 now, HPV hepatitis A and B Tdap booster. And really importantly, the recombinant zoster vaccine, Shingrix.
Who needs Shingrix?
Everyone 50 and over, for sure. But also younger patients over 18, if they're starting certain high-risk therapies like JK inhibitors, get it done before starting the drug.
And cancer screening is also paramount.
Hugely important. We'll get into colonoscopy timing in a bit, but we also need to flag annual pap smears for women on immunosuppression.
And skin checks.
Yes, annual dermatologic exams for everyone on certain meds. Why? Because thiopurines significantly increase the risk of non-melanoma skin cancers, NMSCs.
And anti-TNFs.
There's a noted, though less common, increased risk of melanoma associated with anti-TNF use as well. So skin checks are vital.
You also mentioned a specific group needing immediate screening.
Right. Patients with primary sclerosing cholangitis, PSC, that's the chronic liver disease affecting bile ducts. If a patient has PSC, even without long-standing IBD, they need surveillance colonoscopy immediately upon diagnosis.
Why so urgent?
Because the link between PSC and colorectal cancer is incredibly strong and can develop rapidly, independent of how long they've had IBD. It's a major risk factor. #TAG2, treatment of ulcerative colitis, UC.
Okay, let's shift into therapy, starting with ulcerative colitis. For mild to moderate UC, the first step is usually 5-aminosalicylates, the 5-ASAs.
Yes, and we absolutely have to stress the importance of topical therapy for distal disease proctitis or proctosigmoiditis.
Suppositories and enemas.
Right. Often underutilized, maybe because patients find them inconvenient. But suppositories treat the last 5 to 8 centimeters effectively for proctitis. Enemas can reach much further, often up to the splenic flexure for proctosigmoiditis.
And combining them.
Key clinical point. For disease extending beyond the left colon, combining oral and topical 5-ASA is far superior to just oral therapy alone for getting patients into remission.
The oral pills themselves have interesting designs, right, to release in the colon.
Yeah, they're engineered specifically for that. Some have pH-dependent coatings that only dissolve in the higher pH of the terminal ileum and colon.
And others.
Others use diffusion-dependent matrices like Lialda's MMX technology, which releases the drug more evenly throughout the colon, regardless of pH changes.
Dosing strategy.
And the daily dosing is definitely preferred whenever possible. It just helps patient compliance so much, and better compliance means better long-term outcomes. Simple as that.
Okay. Safety-wise, sulfasalazine often gets singled out.
It does. Because of that sulfa part, it carries specific risks. Nausea, headache, potential myelotoxicity, and notably reversible oligospermia in men.
So stop it if fertility is a concern.
Absolutely. But all 5-ASAs share a rare but serious risk of dose-related kidney problems, interstitial nephritis.
Which means monitoring.
Yes. Checking serum creatinine every 3 to 6 months is essential health maintenance for anyone on long-term 5-ASA therapy.
If 5-ASAs aren't enough, we step up to corticosteroids.
Yeah.
But the rule seems absolute. Induction only, never maintenance. Why so strict?
Because conventional steroids like prednisone cause just unacceptable systemic side effects with long-term use. We're talking bone loss, cataracts, diabetes, hypertension. The list goes on. They're purely a bridge to get the inflammation down.
What are the options?
For mild to moderate UC confined to the distal colon, maybe up to 40 centimeters, we can use rectal butanide foam. It's often easier for patients to administer and keep in than liquid enemas.
And oral butanide, Uceris.
Right, butanide MMX or Uceris. Dosed at 9 milligrams daily for 8 weeks, it's for mild to moderate UC. Its big advantage is high first-pass metabolism in the liver.
Meaning less gets into the system.
Exactly. Minimal systemic bioavailability, so fewer typical steroid side effects compared to prednisone.
When do we use prednisone then?
Conventional prednisone, usually 40 to 60 milligrams for 2 to 4 weeks, followed by a taper, is reserved for more severe cases or those who fail butanide, but the total duration must be limited, ideally 6 to 8 weeks max.
When patients don't respond well to these, or keep needing steroids, we bring in the immunomodulators, specifically thiopurines, azathioprine, AZP, and 6-mercaptopurine, 6-MP.
Correct. They're slower acting, so typically we start them at the same time as a steroid course, giving them time to kick in while the steroids control the flare.
Now, the metabolism here gets complicated. You mentioned 3 pathways.
Yes, and understanding these is absolutely critical for managing these drugs safely and effectively. They're metabolized through 1, the oxidative pathway via xanthine oxidase, XO, making inactive 6-TU. 2, the methylation pathway via the enzyme TPMT, yielding 6-MMP. And 3, the HPRT pathway, which produces the active immunosuppressive metabolites we want, the 6-TGNs.
So we want 6-TGN. Why do we measure 6-MMP and test for TPMT then?
Good question. The AGA recommends TPMT testing before starting, mainly to catch that rare 0.3% of people who are homozygous mutants for TPMT.
What happens to them?
For them, the drug is completely contraindicated. They can't metabolize it properly via that pathway, leading to near certain life-threatening myelosuppression if given a standard dose.
But for everyone else?
For everyone else, the overall rate of blood count problems is actually similar whether you test first or not, because you have to monitor their CVC closely anyway.
But checking the metabolite levels later, the 6-TGN and 6-MMP, that is crucial for management.
Absolutely. It tells us what's going on. If 6-TGN levels get too high, we risk myelosuppression, low white count.
And if 6-MMP is high?
High 6-MMP points towards liver toxicity, maybe nausea. It also tells us the drug might be getting preferentially shunted down that methylation pathway.
Meaning not enough active 6-TGN is being made.
Exactly. Low 6-TGN, despite a decent dose, combined with high 6-MMP, that's often why the drug isn't working well and might be causing side effects. It's shunting.
And this is where that interesting trick with allopurinol comes in.
Yeah.
Usually you avoid that combo.
Precisely. If we see that 6 mmP shunting pattern, we can strategically add low-dose allopurinol, maybe 100 milligrams.
How does that work?
Allopurinol inhibits xanthine oxidase, XO, that first pathway. By blocking XO, it forces the drug metabolism away from the 6 mmP pathway and towards the desired active 6-TGN pathway. It reroutes it.
But that sounds risky. More active drug means.
Exactly. You have to dramatically cut the thiopurine dose, often by 75% or even 85%, to avoid dangerous myelosuppression from suddenly high 6-TGN levels. It requires extremely careful, frequent CBC monitoring.
Okay, very important point. We also absolutely have to mention the severe side effect alert. Hepatosplenic T-cell lymphoma, HSCCL.
Yes. This is very serious. It's a rare but often fatal lymphoma. It primarily hits young men, usually under 35.
What's the risk level?
On thiopurine monotherapy, the risk is already there, but low, maybe 1 in 45,000. But, and this is crucial, the risk jumps significantly, perhaps to 1 in 3,500 for young men on combination therapy with an anti-TNF agent.
Wow, that's a huge increase.
It is, and it fundamentally changes the risk-benefit conversation for that specific group. We really try to limit the duration of combination therapy to less than 2 years whenever we can, partly to mitigate this risk. Hashtag TechTech3, acute severe ulcerative colitis, ASU, and biomarkers.
Let's move to the really acute critical phase, acute severe ulcerative colitis, or HSA. How do biomarkers like fecal calprotectin and CRP help us manage both chronic and acute UC?
They play two distinct roles, really. First, for patients who are in symptomatic remission, the AGA suggests monitoring fecal calprotectin aiming for less than 150 millisieverts rather than just relying on symptoms.
Why?
Because if the biomarkers creep up in someone feeling well, it might signal underlying inflammation returning. That prompts an endoscopy to confirm, letting us catch objective recurrence before a full flare hits. Treat the scope, not just the symptoms.
And the second role is inactive disease.
Right. If a patient has moderate to severe symptoms, really high biomarkers say, FCP over 150 can effectively rule in active inflammation. Meaning that objective data might allow you to make an empiric therapy adjustment, like increasing a biologic dose, without necessarily needing an immediate, potentially difficult repeat endoscopy in a very sick patient.
Got it. Now, when a patient comes in with ASU, the protocol sounds very structured, very time-sensitive.
It has to be. It's an urgent hospitalization. NPO, or clear liquids initially. VTE prophylaxis is absolutely non-negotiable.
Why the emphasis on blood clots?
The risk of venous thromboembolism is 6 times higher during a hospitalized flare. It's a major complication, and we must screen for infections immediately.
Like C. diff.
Stool testing for C. difficile is mandatory, and a flexible sigmoidoscopy with biopsies is crucial to rule out cytomegalovirus, CMV infection. CMV can mimic or seriously worsen ASEC.
Initial treatment is high-dose IV steroids.
Yes. Typically IV methylprednisolone 60 milligrams daily or hydrocortisone 100 milligrams 3 times a day.
What if the patient doesn't respond within that critical 48 to 72 hours?
That's the decision point. If they're not dramatically improving by day 3, you need an early surgical consult for possible colectomy. Time is colon, as they say.
And medical rescue options.
The two mainstays have been infliximab and cyclosporin. Infliximab, usually 5 milligram IV induction, is highly effective. Studies show lower colectomy rates at 3 months compared to placebo.
There are notes about possibly using a higher dose, 10 milligrams, for infliximab sometimes.
Yes, this is a bit nuanced, related to pharmacokinetics in really sick patients. ASU patients often lose a lot of protein through their damaged gut, leading to hypoalbuminemia, low serum albumin, maybe below 2.5 GDL.
And albumin matters because?
Albumin carries infliximab. Low albumin means the drug gets cleared faster, potentially leading to subtherapeutic levels right when you need it most. So considering 10 milligrams in those specific patients with very low albumin is an attempt to overcome that rapid clearance.
Makes sense. What about the alternative, cyclosporin?
Cyclosporin, given RD at 2 to 4 milligray a day, is also effective, but carries significant toxicity risks, high blood pressure, kidney problems, even seizures. It needs close blood level monitoring and really should only be given by experienced teams.
Any reason to choose one over the other? Or contraindications?
A key point. Cyclosporin is not effective if the patient has previously failed thiopurines. Long-term outcomes between infliximab and cyclosporin rescue are pretty similar, so the choice often comes down to physician comfort and hospital experience, though infliximab is generally easier and safer to manage day to day.
And now there's an emerging small molecule option for salvage.
Yes. Tafasitinib, the JAK inhibitor, this is really promising. The TACOS trial looked at using tafasitinib 10 milligrams orally 3 times a day alongside corticosteroids.
And the results.
Quite striking. They saw an 83% response rate by day 7, significantly cutting the need for colectomy compared to placebo. It gives us a valuable oral salvage option, potentially avoiding IV rescue in some cases. #tag5V. Treatment of Crohn's disease, CD.
Okay, shifting gears completely now to Crohn's disease. The management strategies are quite different, mainly because CD is transmural, goes through the whole bowel wall, and can pop up anywhere in the GI tract.
That's right. So for mild disease, 5 ASAs are mentioned, but their role seems very limited.
Yeah, almost entirely restricted to mild colonic Crohn's disease. They just don't work well for ileitis, small bowel inflammation, or for fistulizing disease, or moderate to severe CD.
So for mild to moderate ileocolonic CD inflammation in the end of the small bowel and start of the colon, the mainstay is still budesonide.
Yes, specifically the controlled ileal release formulation, Endicort. It's designed to target that common area.
Right. Dosed at 9 milligrams daily for about 8 weeks. Like Euceris for UC, it has high first-pass metabolism, so fewer systemic side effects than prednisone.
But there's a key difference in use compared to UC.
Big difference. Budesonide is not recommended for maintenance therapy in Crohn's. Treatment really shouldn't go beyond 3 months. Because it's still a steroid, even if less systemic. Long-term use isn't ideal. If someone needs treatment beyond that 3-month induction, you really have to step up to an immunomodulator or a biologic for proper maintenance.
Okay. For moderate to severe disease, it's conventional steroids like prednisone 40 milligram for induction.
Right, to get the fire out quickly.
But they must be followed immediately by maintenance therapy. Which brings us to methotrexate, MTX.
Yes, MTX is effective for both induction, usually at 25 milligrams weekly, and maintenance, typically 15 milligrams weekly, for patients who are steroid dependent or refractory.
And a critical prescribing point here.
The route. It must be given intramuscularly or subcutaneously. By injection. Oral dosing just isn't reliable enough for achieving therapeutic levels in IBD.
Okay, injection only. I remember the committed trial results seemed to pour cold water on using it with biologics.
Yeah, that's right. The committed trial found that adding ATX to infliximab didn't actually improve remission rates in CD patients who were already responding to infliximab induction.
So its main role today.
It's primarily used as monotherapy for maintenance, especially in patients who can't tolerate thiopurines. It's less common now as an add-on to biologics in CD, unlike in rheumatology.
Safety reminders for MTX.
Absolutely need folic acid supplementation 1 milligram daily, monitor LFTs, liver function tests quarterly, and it's strictly contraindicated in patients with significant liver disease or heavy alcohol use.
What about antibiotics in Crohn's?
Their role is pretty limited, mainly for complications. Think colonic disease or fistulizing disease. Ciprofloxacin and metronidazole are the common ones, but they should not be used just to induce remission in uncomplicated Crohn's.
And a warning about metronidazole.
Yes, long-term use carries a risk of irreversible peripheral paresthesia, numbness, and tingling in hands and feet. That limits how long we can safely use it.
And thiopurines in Crohn's. We talked about them in UC.
Similar role, really, primarily for maintenance of remission, or very importantly, as adjunctive therapy with biologics, specifically to reduce the formation of anti-drug antibodies.
Like we saw in the SONIC trial for infliximab.
Exactly. That's a vital function, helping the biologic keep working long-term. They're not really used for induction alone in Crohn's. #tag V biologic small molecules and drug monitoring.
Okay, now the big guns. The biologics and small molecules. The list is just staggering now. Before starting any of these powerful agents, screening is essential.
Absolutely non-negotiable. Rigorous screening for latent TB, hepatitis B, and making sure all those non-live vaccinations, especially Shingrix for zoster, are up to date before starting.
The choice of which agent to use is becoming incredibly personalized, isn't it? Often driven by other health issues the patient has.
Yes, comorbidities and extraintestinal manifestations, EIMs, play a huge role in decision-making now. It's a key area.
Can you give some examples of how EIMs might sway the choice?
Sure. If a patient has significant joint problems like rheumatoid arthritis, ankylosing spondylitis, or psoriasis, along with their IBD, an anti-TNF agent is often preferred.
Because it treats both.
Exactly. It treats the gut and the joint or skin disease simultaneously. But conversely, anti-TNFs should be rigorously avoided in patients with moderate to severe heart failure, class 3 or 4.
Right.
They carry a risk of actually worsening heart failure symptoms. big contraindication.
Any others like that?
Well, for the JAK inhibitor tofacitinib, if a patient has had a recent major cardiovascular event like an MI, stroke, or even a DVT-PE within the last 6 months, it should generally be avoided due to its own associated cardiovascular and thrombosis risks noted in post-marketing studies.
Okay, let's focus on those newer small molecules.
Yeah.
We have the JAK inhibitors tofacitinib, upadacitinib, and the S1P modulators ozanimod and etrasimod.
Right. The JAK inhibitors, approved for UC and some now for CD, work inside the cell, blocking signaling pathways for various inflammatory cytokines.
And tofacitinib has that black box warning.
It does. The FDA warning highlights an increased risk of serious adverse events, including major adverse cardiovascular events, MACE, blood clots, venous and arterial thrombosis, and malignancy compared to TNF inhibitors in certain populations, particularly older patients with cardiovascular risk factors. That risk profile is why the Shingrix vaccine is so strongly recommended before starting.
And the S1P modulators, how do they work?
They work differently. They regulate lymphocyte migration, basically trapping certain T cells in the lymph nodes so they can't get to the gut to cause inflammation. Ozanimod and etrasimod are examples.
Key risks there.
Their main issue upon starting is a potential for transient bradycardia, a slowing of the heart rate. So they require some initial monitoring, like EKG checks during the first doses.
Now for the trials that are really changing, practice the head-to-head comparisons. We should start with the combination therapy concept from UC Success and Sonic.
Yes, those trials fundamentally proved that, at least in patients new to biologics, 2 is better than 1. UC Success showed infliximab plus azathioprine, AZP, beat either drug alone for steroid-free remission in UC.
And Sonic showed the same in Crohn's.
Mirror image for Crohn's disease, yes. Combination infliximab plus AZP was superior to AZP monotherapy.
But the really crucial finding wasn't just better remission rates, was it? It was about antibodies.
That was the huge takeaway, especially from Sonic. Combination therapy resulted in only 1% of patients developing antibodies against infliximab, compared to 15% in the group getting infliximab alone.
So the immunomodulator protects the biologic.
Exactly. AZP suppresses the immune system's ability to see the biologic as foreign and attack it. This preserves the drug's effectiveness long-term and dramatically reduces secondary loss of response due to antibodies.
Okay, then Varsity. This compared a gut-selective drug versus a systemic anti-TNF in UC.
Right. Varsity was a landmark head-to-head. Vedolizumab, which is an anti-integrin that works primarily in the gut, versus adalimumab, a systemic anti-TNF.
And the winner.
Vedolizumab came out on top. It was superior to adalimumab for achieving clinical remission and, importantly, endoscopic improvement at 52 weeks in moderate to severe UC, even in patients who hadn't had biologics before.
How has that impacted guidelines?
It's had a major influence. The AGA guidelines now recommend vedolizumab over adalimumab as a first-line biologic choice in naive UC patients, prioritizing that gut-selective approach and mucosal healing for UC specifically.
Okay, and for patients who have already failed an anti-TNF in Crohn's, the Sequence trial gives us guidance.
Sequence is very important for that scenario. It compared 2 drugs targeting the IL-12/23 pathway, risankizumab, which targets just IL-23, versus ustekinumab, which targets both IL-12 and IL-23. This was in CD patients who had already failed anti-TNF therapy.
And the result there.
Risankizumab showed significantly higher rates of both endoscopic remission and mucosal healing at 24 and 48 weeks compared to ustekinumab in this specific, harder-to-treat population.
So it suggests a potential preferred next step after TNF failure.
It does. It gives us valuable data suggesting that risankizumab might be a more effective option than ustekinumab for achieving deep remission in patients who are TNF refractory.
Before we get to drug monitoring, let's quickly touch on biosimilars. What are they exactly?
Right. Biosimilars are highly similar, but importantly, not identical, versions of existing approved biologics, the reference product. They aren't generics like for small molecule pills.
Why not generics?
Because biologics are large, complex molecules made in living systems. You can't make an exact copy. Biosimilars have to demonstrate through extensive testing that they have no clinically meaningful differences in safety, purity, and potency compared to the original, even if there are minor differences in things like glycosylation patterns.
The goal is cost savings.
Primarily, yes. Cost reduction and increased patient access.
Is switching safe?
The big North-Switch study provided a lot of reassurance globally. It looked at switching patients from originator infliximab to a biosimilar, CTP13, across many diseases, including CD and UC. The finding was non-inferiority switching was just as safe and effective as staying on the originator. So yes, switching is generally considered safe.
Okay. Finally, therapeutic drug monitoring, TDM. Two main approaches, reactive and proactive.
Reactive TDM is the standard of care, recommended by guidelines. You measure drug trough levels and antibody levels when a patient isn't responding well, either primary non-response, never worked, or secondary loss of response, worked but stopped.
And the results guide changes.
Exactly. If the drug level trough is too low, you might increase the dose or shorten the interval. If antibody levels are high, that suggests immunogenicity, so you might need to add an immunomodulator or switch to a different class of drug.
That makes sense. Proactive TDM feels different, though, more preventative.
It is, and it's definitely where the field is heading, especially for the anti-TNF agents where we have the most data. Proactive TDM means measuring drug levels periodically in patients who are actually doing well, asymptomatic.
Why do that if they feel fine?
The goal is to optimize dosing to prevent loss of response before it even happens, and also to ensure we're hitting targets associated not just with feeling better, but with actual mucosal healing.
Are there specific target levels?
Yes, particularly for infliximab and adalimumab. For example, with infliximab maintenance, a minimum trough level around 3 megamel might be enough for clinical response, but data strongly suggests a level over 7 megamel is associated with better rates of mucosal healing.
So proactive monitoring helps you fine-tune dosing to hit those higher targets.
Precisely. Especially in patients known to clear the drug faster, like young males with high BMI and low albumin. It allows personalized optimization for better long-term outcomes. #tagged high TB IBD in colorectal cancer, CRC, and perianal disease.
Let's turn to a really critical issue, the link between IBD and colorectal cancer, CRC, and how we manage surveillance. What makes an IBD patient's CRC risk higher than average?
Several factors increase the risk. Established ones include being male, having IBD diagnosed at a younger age, say under 30, having extensive colitis inflammation involving a large part of the colon, and, as we mentioned, having concurrent primary sclerosing cholangitis, BSC.
Family history matters too.
Yes, having a first-degree relative, like a parent or sibling, diagnosed with CRC before age 50 also increases the risk.
It feels important to clarify the actual risk level because some older studies reported really scary high numbers.
That's a very important point. Older studies, often from specialized referral centers, suggested incredibly high cumulative risk, sometimes like 18% after 30 years of disease. That caused a lot of fear.
But newer data.
More recent, large population-based studies paint a different picture. They still show an increased risk, about a 1.7 times higher standardized incidence ratio compared to the general population. But the cumulative incidence over 30 years is now estimated to be closer to 4.5%.
Still higher, but maybe not as terrifyingly high.
Exactly. It allows for more realistic counseling, although patients with extensive colitis, or PSC, still face a significant absolute risk that needs careful management.
So when should surveillance colonoscopy actually begin?
The standard recommendation is to start screening colonoscopy 8 to 10 years after the initial IBD diagnosis. This window gives us time to detect dysplasia, those precancerous changes, before it progresses to cancer.
Unless they had PSC.
That's the big exception. If PSC is diagnosed, surveillance must begin immediately, regardless of how long they've had IBD, because of that uniquely high and rapid CRC risk.
Now, the technique during colonoscopy is debated. High-definition white light with random biopsies versus chromodoscopy with targeted biopsies.
The thinking has really shifted towards finding and removing visible lesions. The acinic consensus statement favors chromoendoscopy.
That's using dye spray.
Yes.
Yeah.
Using dyes like indigo carmine or methylene blue to spray onto the colon lining. It highlights subtle abnormalities, bumps, or depressions that might represent dysplasia. Then you biopsy those targeted spots.
Why is that preferred over random biopsies?
Because we now know that the vast majority of dysplasia, probably over 98%, is actually visible endoscopically if you look carefully, especially with high-definition scopes and maybe chromo. Random biopsies of normal-appearing mucosa have an extremely low yield finding dysplasia. That way is rare, maybe 0.2% or less.
The targeted is better.
Generally, yes. Targeted biopsies are much higher yield. However, random biopsies might still have a role in very high-risk patients, like those with PSC or a history of dysplasia, or just to document the extent of microscopic inflammation. But the focus is finding visible stuff.
And the terminology for what we find has changed too. No more DOM?
Correct. Dallin dysplasia-associated lesion, or mass, is basically retired terminology. The focus now is simpler. Is the dysplasia visible or invisible? And if visible, is it resectable endoscopically?
How does that guide management?
If you find a visible lesion that looks resectable, the goal is complete endoscopic removal, preferably using en bloc resection techniques like EMR or ESD to get it all out in one piece for the pathologist.
What if it's unresectable or high grade?
Any lesion that's clearly unresectable endoscopically, or if biopsies confirm multifocal dysplasia in multiple spots, or any confirmed high-grade dysplasia that requires immediate surgical referral for proctocolectomy, the cancer risk is just too high for continued endoscopic surveillance.
Okay. Shifting slightly to perianal and fistulizing Crohn's disease, there's another malignancy warning here.
Yes, unfortunately. Chronic, long-standing inflammation and scarring from perianal Crohn's disease, especially complex fistulas, carry a risk of malignant transformation over time, usually into anal squamous cell carcinoma.
Is there an association?
It's often associated with concurrent HPV infection, similar to anal cancer in the general population. We advise considering anal pap smear screening for high-risk patients, like those with long-standing perianal CD.
And managing the perianal disease itself, what's the first step?
For active perianal disease, especially with abscesses, surgery comes first. Early surgical examination under anesthesia and drainage of any significant perianal abscess, say bigger than 5 millimeters, is mandatory before you even think about starting anti-TNF therapy.
Why drain first?
Because starting a potent immunosuppressant like an anti-TNF on top of an undrained pocket of infection can lead to disastrous worsening of the infection, potentially sepsis. Drain first, then treat medically.
Which biologic has the best evidence for helping fistulas heal?
Infliximab still holds the strongest evidence base for inducing and maintaining fistula closure in Crohn's disease.
Is it used alone?
Often, combination therapy works better. Using infliximab plus antibiotics, typically ciprofloxacin or metronidazole for a course, is generally more effective for achieving fistula healing than using the anti-TNF by itself. #tag77, surgical management and fertility pregnancy.
Surgical intervention is often curative for UC, but for Crohn's, it's more about managing complications. Let's start with UC surgery. The common procedure is the ileal pouch anal anastomosis, or IPAA, the J pouch. There are two main ways to connect the pouch.
That's right, the anastomosis itself. You have the hand-sewn approach. This requires a mucosectomy, physically stripping out all the remaining diseased rectal mucosa down to the dentate line.
Benefit of that.
Minimizes the risk of inflammation or cancer developing later in any residual rectal tissue. But the downside is often a higher risk of incontinence and potentially anastomotic leaks because the dissection is lower.
And the alternative?
The stapled approach. Here, the anastomosis is done higher up, leaving a short cuff, maybe 2-3 centimeters, of the patient's original rectal mucosa above the staple line.
Advantage there.
Generally preserves better anal sphincter function and results in better continence. But the trade-off is you've left behind that small cuff of rectal tissue, which carries a risk of chronic inflammation, cophitis, and, although small, a theoretical risk of developing dysplasia or cancer in that cuff over time.
After the pouch is created, the most common problem seems to be pouchitis.
By far. It affects a huge number of patients, maybe up to 51% by 48 months after surgery.
How is it diagnosed? Symptoms aren't enough.
No. Symptoms like increased frequency, urgency, cramps, they're notoriously unreliable. You can have irritable pouch syndrome. The diagnosis of true pouchitis requires objective evidence of inflammation seen during pouchoscopy with biopsies.
And treatment.
First-line treatment is a course of antibiotics, usually metronidazole or ciprofloxacin, typically for 2 weeks.
What if it keeps coming back? Chronic pouchitis.
For chronic antibiotic-dependent or refractory pouchitis, we now have evidence that the anti-integrin biologic vedolizumab can increase remission rates compared to placebo. So that's an option.
Any role for probiotics?
Yes, specifically the high-potency probiotic formulation VSL-3 or its equivalent Visbiome. It has good evidence both for preventing relapse after antibiotic treatment and potentially as primary prophylaxis to prevent the first episode of pouchitis in some patients.
Okay, let's switch to surgery for Crohn's disease. Here, recurrence seems almost inevitable.
It's incredibly common, unfortunately. Endoscopic recurrence inflammation seen on scope at the anastomosis or in the neoterminal ileum happens in 70% to 90% of patients within just 1 year of resection.
And clinical recurrence. Symptoms coming back.
That follows, usually lagging behind the endoscopic findings. About 30% have clinical recurrence at 1 year and maybe 50% by 5 years post-op.
So how do we manage this high recurrence risk after surgery?
Post-operative prophylaxis is absolutely crucial. You can't just resect and wait for symptoms. And anti-TNF therapy is clearly established as the single most effective intervention to reduce recurrence risk.
The POC trial gave us a roadmap for this.
Yes, the PSOCHIRA trial was really important. It tested an active management strategy. Instead of just treating symptoms if they occurred, they performed a mandatory surveillance colonoscopy at 6 months post-surgery on everyone.
What did they do based on the scope?
They used the Rutgers score to grade recurrence. If significant recurrence, Rutgers I2 or higher, was found, even if the patient felt fine, drug therapy was immediately started or escalated.
And the result?
This active scope-driven management led to significantly lower rates of endoscopic recurrence at 18 months, 49% versus 67% in the group getting standard care based on symptoms. Treat the scope.
Okay, let's define that surveillance timing in the Rutgers score more clearly.
Post-surgery for Crohn's, a colonoscopy must be done at the 6 to 12-month mark. During that scope, you assess the anastomosis itself and the neoterminal ileum, the piece of small bowel just before the joint.
And the score?
The Rutgers score grades what you see. I0 or I1 means remission, or only a few small ulcers, generally good news. I2, I3, or I4 indicate progressively more severe inflammation and ulceration, signaling recurrence that needs treatment escalation.
Does fecal calprotectin help here too?
Yes, it's proving very useful in the post-op setting.
How so?
Follow-up data from POCers show that if an asymptomatic patient has a low fecal calprotectin, specifically less than 100 beg, it has a very high negative predictive value, around 91%.
Meaning if it's low, they probably don't have significant recurrence.
Exactly. It suggests you can reliably rule out significant endoscopic recurrence, like Rutgers I2 or higher, in that asymptomatic low FCP patient, potentially allowing you to safely defer the 6-month colonoscopy or push it out a bit. It acts like a gatekeeper.
Very helpful. Lastly, for CD surgery, quick note on managing strictures that form.
Right. Crohn's can cause scarring and narrowing or strictures. Endoscopic balloon dilation is the main non-surgical treatment for accessible short strictures, ideally less than 4 centimeters long. These can be inflammatory or fibrotic.
How big do you dilate?
You gradually inflate a balloon across the stricture. We typically limit the maximum dilation diameter to 18 or maybe 20 millimeters to minimize the risk of perforation.
When should you not dilate?
Dilation should generally be avoided if the stricture looks very inflamed with deep ulcers nearby, or if there's evidence of a concurrent abscess or an active fistula associated with it. Too risky for perforation or worsening infection.
Okay, let's wrap up with fertility and pregnancy, obviously a huge area of concern for many young IBD patients.
Absolutely critical. And the single most important principle is this. Maintaining disease remission before conception and throughout pregnancy is the strongest predictor of good outcomes for both mother and baby.
Active inflammation is bad for fertility and pregnancy.
Significantly so. Active inflammation decreases fertility rates and clearly increases the risks of adverse pregnancy outcomes like preterm birth and low birth weight. Also worth noting, IPA pouch surgery itself, because of the deep pelvic dissection, can unfortunately decrease fertility rates in women afterwards, although maybe less so with laparoscopic techniques.
What about medication safety during pregnancy? Which ones need to stop and which are okay?
This is key counseling. Sulfasalazine needs to be stopped ideally 3 months before conception in men because it causes that reversible oligospermia, low sperm count.
Okay.
Methotrexate is the big NO, absolutely contraindicated for both women and men planning conception. It must be stopped at least 3 months prior in both sexes due to risks of birth defects, teratogenicity, and miscarriage.
But the good news?
The good news is that most of our common IBD maintenance medications, the 5 ASAs, the thiopurines, AZP6MP, and most biologics are considered safe and compatible with pregnancy and breastfeeding. Keeping the disease controlled is paramount.
Biologics do cross the placenta,
yes.
Right? Mostly later in pregnancy.
Yes, the IgG1 and IgG4 antibody-based biologics, so that's most of them like infliximab, adalimumab, vitalizumab, ustekinumab, golimumab, rely on active transport across the placenta via the FcRn receptor, mainly during the 3rd trimester.
So do we adjust dosing near the end?
It's often recommended. To minimize the amount of drug in the baby's system at birth, the dosing schedule for these biologics can sometimes be adjusted. The goal is to have the last dose timed so the trough level occurs earlier, maybe around 30 to 38 weeks, allowing a longer drug-free interval before delivery.
But there's one major exception to that placental crossing rule.
Yes, certolizumab, Pegol, Cimzia. It's unique.
Why?
Because molecularly, it's different. It's a pegylated Fab fragment. It lacks the FCZ region of the antibody that's necessary for that active FcRn-mediated transport across the placenta.
Meaning very little gets across.
Minimal placental transport. Because of this fundamental difference, no specific scheduling adjustment is needed for certolizumab before delivery. This makes it an attractive option for some physicians and patients who want to minimize fetal drug exposure near term.
Okay. After the baby is born, what's the advice regarding infant live vaccines?
This is a slightly evolving area, but caution is still advised. Because biologics, except certolizumab, are present in the infant's circulation for some months after birth, there's a theoretical risk if the infant receives a live vaccine too early.
Like rotavirus.
Rotavirus is the main live vaccine given routinely under 6 months in the U.S. Based partly on one reported fatal case involving the BCG vaccine not used in the U.S. in an exposed infant years ago, guidelines generally recommend withholding live vaccines like rotavirus for infants exposed to biologics in utero for the first 6 months of life.
Except if the mother was on certolizumab.
Correct. Certolizumab exposure doesn't warrant holding live vaccines, and it's worth noting that some newer evidence is suggesting the actual risk from rotavirus vaccine might be very low even with exposure, but the cautious approach generally prevails for now.
And breastfeeding. Safe with biologics.
Yes. All biologics are considered compatible with breastfeeding. Levels detected in breast milk are typically very low. The drug is likely digested in the infant's gut, and studies have not shown any adverse effects on infant development or infection rates. So, breastfeeding should be encouraged.
That brings us to the end of an incredibly dense, but hopefully clarifying deep dive. The synthesis seems clear. IBD care has really shifted. The focus is definitively on objective targets, now endoscopic healing, treat to target using biomarkers, TDM.
Absolutely. And it's also about personalized preventative care across the whole patient journey, health maintenance, meticulous postoperative management, careful planning around life stages.
Yeah. If we connect this back, thinking about the complexity of, say, manipulating thiopurine metabolism with allopurinol.
Oh, that huge jump in HSTCL risk for young men on combo therapy.
And the head-to-head trial data like varsity and sequence guiding choices. I wonder, are IBD treatment decisions now driven more by the pure molecular mechanism and the hard trial data?
Or are they increasingly dominated by the sheer necessity of navigating and mitigating risks tied specifically to the individual patient, their comorbidities, their age, and crucial life stages like wanting to start a family?
It's a fascinating tension, isn't it? Maximizing efficacy versus ensuring safety in a very personalized way. Definitely something for you, the listener, to think about. And you should certainly delve deeper. There are fantastic resources out there, ibd-eii.com for guidelines, and crucial patient-focused sites like Mother to Baby and ibdparenthoodproject.org. Keep exploring.